Our next speaker is Dr. Sadhana Patwardhan. She is director of Nagpur Test Tube Baby Center and also a senior consultant obstetric and gynec at Ketkar Hospital, Nagpur. She is a clinical secretary Maharashtra State Chapter ISAR for 2018 up to 2020. She is the recipient of many national and international awards, including prestigious CL Zaveri Award Foxy 2000. We welcome Dr. Sadhana Patwardhan for giving a talk on how to improve success in IUI. Dr. Sadhana.
Good afternoon, everybody. Respected chairperson, senior members in the audience, dear friends and colleagues. I am thankful to the organizing chairperson and secretary for having given me this opportunity to discuss with you this important topic of optimizing success in IUI. I am much more thankful to the audience who is here even for the last talk of this session. I am indeed very happy to see such a large gathering here. In the next 20 minutes of my talk, what I would be discussing is not only how we optimize the IUI success rates, but also a critical appraisal of the procedure which we have been doing for the last 2 to 3 decades. Purnima has very nicely elucidated the use of gonadotrophins in the rationalistic treatment of this procedure. Let us see how we go about optimizing our IUI results in the lab. Just to share with you a news report which I read, that scientists just discovered a brand new part of the sperm that could explain infertility. This was a topic written by Jacinta Bowler, and she says that sperms have been having a tough time lately. The concentration per ejaculate is getting lower. Scientists have created an artificial version that could one day replace it. And to make matters worse, the common household products might affect the quality of these little guys. What the researchers from the University of Toledo found that there is a second extracentriole in the sperm, which the researchers call an atypical centriole, and this guy has weird properties too. To start with, although they have the same functions, these two centrioles look very different. So what is the point which I want to bring home is abnormalities in the formation and function of this atypical centriole may be the root of infertility of unknown cause in couples who have no treatment options available to them. So now coming back to IUI, the first paper entitled Intrauterine Insemination was published way back in 1962, and since then IUI has evolved through innovations as sperm preparation, monitoring for the pre-ovulatory timing, and induction of ovulation with human chorionic gonadotrophin. IUI also has been combined with ovarian stimulation using clomiphene citrate and gonadotrophins. The European IVF monitoring program in 2004 reported 98,388 IUI cycles from 19 countries, leading to 12,081 births, of which 87% were singleton and 13% were multiple births. So with such a large data which has been accumulated over the last 4 decades, this is the time to assess the evidence on the effectiveness of the procedure called IUI. Can I have a pointer? So if you see the utilization of IUI, what you see as the years are going by, the number of participant countries are also increasing. The number of IUI cycles are also increasing sizably. But if you see the pregnancy rates, there is no significant increase in the pregnancy rate. Now friends, this is not only true with the homologous IUI samples, but also with the donor insemination cycles. So when we discuss the indications for IUI treatment, we all know that the rationale of IUI treatment is to increase the rate of conception in the couple by increasing the chance that maximum number of healthy sperms they reach the site of fertilization. And we all know that IUI is contraindicated in women with cervical atresia, cervicitis, endometritis, bilateral tubal obstruction, and in most cases of amenorrhea and severe oligospermia. So when we talk of indications, IUI with or without ovarian stimulation is considered to be indicated for a broad range of diagnostic conditions, for male infertility, for unexplained infertility. Now this is a group about which all of us are confused all the time. So the Eshrey Capri workshop group has put unexplained infertility as such into three broad categories: 20% of couples after the initial workup, couples with mild male subfertility, and 50% of couples in whom conventional treatments have failed. So these are the three broad categories of patients who come in unexplained infertility: minimal mild endometriosis, and then IUI is an empiric treatment, since it is likely that majority of infertility involves factors that are untreatable or unknown. So the potential unknown defects are unexplained infertility. Why? Because we have no test for the oocyte quality. Now could it be a structural defect in the oocyte chromosome, that there may be a high percentage of 75% post-fertilization failure rate even in IUI patients who fail to conceive despite everything being normal. Total fertilization failure does not seem to be a dominant feature in patients who undergo IUI. Then, are you looking at failure of uterine receptivity and implantation? Because we know that successful completion of each stage depends on numerous enzymatic processes. Thus, IUI is prescribed in a wide variety of presumed diagnoses, even if in some of them the rationale for the use would be debatable. Discussing some important points which correlate with the success rate in IUIs, few of them are semen preparation. Now, a systemic review of the sperm preparation techniques concluded that there was insufficient data which was in randomized studies still to choose the best method. However, a total motile sperm count of 10 million may be a useful threshold value for decisions regarding the treatment of couple with IU or IVF, though 5 million is widely accepted. The next important point is just this chart is highlighting for you the two most common methods which we are using, the pellet swim up and the gradient centrifugation. And then the third important part is monitoring of a stimulated cycle. We need to see the patient on the second or the third day for baseline transvaginal sonography. We stimulate with oral ovulogens or gonadotrophins only after confirming that there is no follicle more than 9 millimeter and endometrial lining is thin. Now, why this is important? Because this has indicated that the patient has had a good estrogen progesterone withdrawal bleeding and her estradiol value must be less than 30. Now, monitoring of a stimulated cycle is also very important. Usually we ask the patient to keep relation on the 6th day of the menses so that at the time of IUI there won't be prolonged abstinence. Patient is called on the 8th or 9th day of the cycle for follicular monitoring, and depending on the size of the follicle you call the patient daily or on the alternate days. It is advisable to see the patient daily once the follicle reaches 16 millimeter. If the patient is on gonadotrophin stimulation protocol, the gonadotrophin should be continued till the day of ovulation trigger. Usually the ovulation trigger is given when the follicle is 19 millimeter. By this 1 millimeter of human error is allowed as the ideal size of follicle when the trigger should be given should be 18 to 20 millimeter, more so in clomiphene induced cycles because the follicle size tends to be a little larger. So, gonadotrophins in IUI stimulation, I will not highlight this much. We are either using clomiphene citrate or letrozole. We usually start from day 3, we continue till day 7. Role of adjuvants, so many deliberations and discussions have been going on since the last 2 days, but however we use the adjuvants. You do a sonography on day 10 and as soon as the follicle size reaches 1.8 to 2, you give your trigger and you plan your IUI 36 hours later. In PCO patients, when you want to use gonadotrophin, we usually use follicular stimulating hormone, and in non-PCOS and elderly patients we use the HMG. Now, timing of ovulation trigger. In order to optimize the IUI results, ovulation trigger is given when the leading follicle is 18/20. If an early or a late trigger is given, it can cause failure to ovulation. Sometimes even if ovulation takes place, it will be premature or a post-mature egg, and hence the fertilization fails or the fertilized embryo is not of good quality. Ovulation trigger can be given by urinary HCG 10,000 units. Do not compromise by giving 5,000 units. Recombinant HCG 250 and a GnRH agonist in the dose of 1 milligram. This is just a flow chart telling you, all of you must be well aware of all this, but I thought I might as well include this in my talk. So, the mode of insemination, just a small slide on this, a small detailed discussion is, IUI is performed commonly using 0.2 to 0.5 ml of sperm suspension. Clinics with better success rate, however, use 1 ml for IUI to overcome the collective loss of fluid during the various stages of loading the catheter. And then whether you need to immobilize the women or you do not need to immobilize. So, a randomized clinical trial compared immobilization for 15 minutes with immediate mobilization subsequent to IUI and showed a higher PR in the first group. The suggested gap between the IUI procedure and the semen wash should be less than 40 minutes. The IUI procedure, all of you know, a sterile tolly. The semen sample is filled with an air gap. It is loaded in a BD syringe. The sterile non-toxic catheter is taken. The sample is pushed up to the tip of the catheter. The patient is laid in the dorsal position. Expose the cervix with a bivalve cusco speculum. Introduce the catheter in the cervical canal. Push the sample slowly. Wait for a few seconds and withdraw the catheter to prevent the reflux. Now, timing of IUI insemination is another important thing. There are two schools of thought, either a single IUI which can be performed at 36 hours or double IUI can be performed at 24 and 40 hours. The Cochrane database review in 2003 and 2007 revealed that there was no statistical significance between single and double IUI success rate, but the 2010 Cochrane database review concluded that double IUI resulted in significant benefit over single IUI in treatment of subfertile couples with husband. Another important point we all need to keep in mind is IUI and the endometrium. The pregnancy rates are significantly higher in patients with an endometrium of more than 9 millimeter, while thin endometria, generally measuring less than 7 millimeter, are thought to be less able to support implantation in pregnancy. So, what are the strategies? This has been discussed: low dose aspirin. You counteract the anti-estrogenic endometrial effect of clomiphene by co-treatment with ethinyl estradiol and GCSF instillation. So, now to critically evaluate the IUI in cycles stimulated with clomiphene in unexplained infertility, the sequential management trial indicates that pregnancy rate per cycle are high enough to merit CC-IUI treatment for unexplained infertility in lieu of more costly and complex FSH-IUI treatment. As far as male infertility and other diagnoses are concerned, there are no trials evaluating CC-IUI in male infertility and diagnosis which met the inclusion criteria. Now, IUI in FSH stimulated cycles, when we are using the classical dose, IUI combined with FSH aimed in the past to develop multiple dominant follicles, leading to availability of multiple oocytes for fertilization. So, the overall likelihood of conception is increased because you have more number of follicles, but the added value of ovarian stimulation is limited because you have multiple gestations. So, now three questions which are relevant are here are whether FSH-IUI is superior to no treatment, whether FSH-IUI is more effective than clomiphene, and FSH-IUI whether it is superior to IUI alone. So, the recent Cochrane meta-analysis has however addressed question number 2 and 3. So, FSH and IUI superior to no treatment, there are no Cochrane reviews. FSH-IUI whether it is more effective with gonadotrophins than with CC? This question was addressed in one section, and in 7 trials with 556 couples with unexplained infertility, mild male factor and mild endometriosis, pregnancy rates were definitely higher with gonadotrophins than with anti-estrogen. Now, when FSH IUI was compared to IUI alone, a meta-analysis reported that live birth was significantly more likely with IUI and ovarian stimulation than with IUI in the natural cycle in 4 trials amongst patients with unexplained infertility. The overall likelihood of conception was increased, but the added value of FSH was limited and multiple gestations occurred frequently. They had a multiple pregnancy rate of 29%, which is very high. So now should we come over to low dose gonadostimulation? Mild stimulation, can it maintain an overall pregnancy rate? The higher the number of released oocytes, the higher is the chance for at least one embryo to implant. High responsiveness, better ovarian reserve. So are the oocytes of good quality, higher quality? So if multifollicular responses reflect oocyte quality more than the gonadotrophin dose, then the future strategies for ovarian stimulation should aim to achieve optimal monofollicular growth, and the rate of multiple births would be minimized without impairing the pregnancy rate. Now, what are the conditions affecting the prognosis? Success rate with FSH and IUI will depend on the age of the female partner. The quality of the ovarian response is a less certain predictor. A significant proportion of stimulated cycles remain monoovulatory. However, 15% over-respond. In contrast, we need to find out a relation between the follicular number and multiple gestation. So, effectiveness of IUI in mono or bifollicular cycles would further change our treatment choices, but at the moment, for safety reasons, many North European clinics are not using gonadotrophin. What about the premature LH surge in IUI cycles? A premature LH surge is a premature rise of LH more than 10 accompanied by a concomitant rise in progesterone. Premature LH surges occur in 25 to 30% of stimulated IUI cycles. So theoretically, they may interfere with the timing of IUI or result in cancellation and more treatment failures. Administration of an antagonist would abolish this premature luteinization. There would not be much improvement in the pregnancy rate because you would have had a poor quality of the growing follicle. Luteal support is another question. Luteal phase after ovarian stimulation. The luteal phase of a stimulated cycle, as Purnima has told us, is accompanied with high level of estradiols and progesterone. The level of LH and FSH come down to low levels. Low levels of LH, luteotrophic support is needed because you have a low level of progesterone. Again, the high level of estradiol also leads to inappropriate hormonal priming of the endometrium. So, what are the clinical decisions about IUI and IVF? In unstimulated IUI does not significantly increase the pregnancy rate. When you are doing clomiphene and IUI, you have a 5 to 7 pregnancy rate per cycle even after 7 cycles. IUI and ovarian stimulation, you have a modest effect with a risk of multiple pregnancy and OHSs. IUI and mild ovarian stimulation, the efficacy needs to be confirmed by large studies because we do not yet know the low dose gonadotrophin, which dose can be used for getting us the better results. As far as IVF concerned, you all know there is a 7-fold higher likelihood of pregnancy, and ICSI is better than IVF in couples with severe male infertility. So the treatment plan is, despite the extensive literature, controversy remains about the order of treatment, the effectiveness of the stimulated IUI cycle
Doctor, but may I
in
please
IVF
request you to
and
please sum it up
ICSI.
in next 60 seconds. Thank you.
Just a minute. Management trials are needed to address these questions. Such trials should evaluate not only the success rate but also important outcomes such as availability of methods, adverse effects, satisfaction, likelihood of resolution and cost, together with the analysis of the invasiveness of the techniques and the likelihood of the couple compliance. So so in good prognosis couple patient, the live birth rate is better without treatment. IUI is widely used with infertility diagnosis other than bilateral tubal obstruction, severe male infertility and severe ovulation defects. And to conclude, although IUI treatment is cheaper and less demanding on the patient, IVF is more of a cost-effective treatment, and there is a need for management trials to evaluate the order of treatment and overall effectiveness of the treatment strategies in more clinical and cost settings. And I thank you all for a patient hearing.